Good morning, everyone. Welcome to the breakfast at UMHealth this morning. My anesthetic team this morning is going to share an anesthetic topic, actually, malignant hyperthermia. It's a rare crisis that unfortunately we've encountered 2 cases recently. So first up, Dr. Yip Hing Wa is our clinical specialist, will present the cases that have happened, followed by Professor Shahnaz. He will give a discussion on the topic. So I think it's good that we share the information, knowledge, and also awareness across all teams this morning. So let's welcome Dr. Yip.
Hello, good morning. I'm Dr. Yip from Department of Anesthesia. I will start my presentation by introducing these 2 cases that happened recently in our department. Case number 1 is elective surgery. It's a 21-year-old female who is electively admitted for total thyroidectomy for Graves' disease. She is clinically euthyroid and there's no obstructive or compressive symptoms. She has been compliant to the thyroid medications with normal thyroid function test upon admission. On the day of surgery, induction of anesthesia was uneventful. She was pre-oxygenated and given IV fentanyl and propofol. Intubation was done smoothly without needing muscle relaxant. The anesthesia was maintained with the volatile agent, which is desflurane and remifentanil infusions. However, 3 hours during operation, she developed a rapid rise in temperature. The temperature was rise from 36 to 38.5 degrees Celsius within 30 minutes, despite given cold IV drip infusions. The end tidal CO2 was rise rapidly as well, despite increasing minute ventilation. Her BP was unsupported throughout during that time, and the heart rate was ranged 60 to 80. There was no tachycardia. However, the first ABG taken during that time already showed respiratory acidosis with a CO2 of 62, and the metabolic acidosis was slowly developed with a lactate 4.6. During that time, the impression, we would think of it could be a malignant hyperthermia, and it could be a thyroid storm as well, given the underlying medical history. The immediate action was taken, surgeon was alerted, help was called, and MH code was activated. The new GA machine was changed immediately with a volatile agent free. So the anesthesia was maintained with a total intravenous anesthesia method with an infusion of propofol and remifentanil. Arterial line and central venous line was inserted for invasive monitoring, and further cooling therapy was instituted. At the same time, the treatment for thyroid storm, esmolol and hydrocortisone was given at the same time while waiting the dantrolene to arrive. So we have given almost 6 vials of dantrolene, and half the dose of dantrolene was administered. Her condition improved. Initially, she doesn't need any inotropic support, but until we changed to a new GA machine, she needed some inotrope and there's tachycardia. But after the dantrolene, everything reverted to normal. The end tidal CO2 also come down from 100 to 40. Temperature also dropped from 41.9 to 37. Acidosis also better with the lactate improved and the CO2 slowly coming down. The surgery was completed and the patient was transferred to ICU for close monitoring. In the ICU, she remained hemodynamic stable, temperature never spike of fever again, and there's good urine output. The sedation was off and she was successfully extubated after 8 hours. She was then monitored in ICU for another 24 hours and discharged to ward. In the ward, she was further monitored for 72 hours and then discharged home with the MH card as shown in the presentation. The blood result on the 23rd, which was the day of surgery, after the event happened, the potassium and the creatinine has actually doubled up. And 24 hours later, the CK level was shot up to 2000 and then it calmed down with our treatment. A month later, the second case, which was done under emergency setting, she is a 36-year-old with an 8-week of gestation age and a very small sized lady. She has underlying scoliosis diagnosed since age of 17 and defaulted follow-up. She was suspected to have a ruptured ectopic pregnancy with a stable hemodynamic and planned for an emergency laparotomy and self-injectomy. Induction of anesthesia was uneventful. The endotracheal tube intubation was uneventful, and the anesthesia was maintained with the volatile agent desferrine. Arterial line was inserted for potential massive blood loss and fluid shift. However, intraoperatively, she developed a persistent hypotension despite fluid resuscitation, and her BP was not responded to vasopressor. And slowly, the end tidal CO2 was rise rapidly despite increasing minute ventilation. Temperature also rise despite cooling therapy. The AVG shows that severe mixed respiratory and metabolic acidosis. During that impression, it could be a malignant hyperthermia, and it could be a septic shock as well. So surgeon was alerted. At that time, the surgery almost completed. So the GA machine was detached from the patient, and she was connected to an external oxygen tank to eliminate the volatile anesthetic agent. At the same time, denturing was given and continuous external cooling was done. After the denturing administration, the end tidal CO2 normalized back to the normal value, temperature also back to baseline. She was otherwise stable without needing vasopressor and inotherapeutic support after the denturing administration. So she was then transferred to ICU for close monitoring and successfully extubated after 24 hours. She was further monitored in the ward for 48 hours and discharged home well. Again, 30th will be the date of surgery, and during that time, her HP was dropped. And few hours later, after the MH event was suspected, we can see that the potassium was raised to 5.6, and the CK peaked after 24 hours to close to 1,000. So both case was presented a very non-specific way. So that comes to the introduction of the malignant hyperthermia, a rare but life-threatening anesthetic emergency. My presentation will include following parts: the introductions of the MH, the pathophysiology, the clinical manifestation, and the possible differential diagnosis. And we'll touch about the management principle, which is denturing, and how to manage the sequelae of the MH, and what are the ongoing care for the MH susceptible patient, and how's the counseling after the acute event, and management of the MH susceptible individual for future anesthesia. Malignant hyperthermia is a progressive life-threatening hyperthermic reaction occurring during general anesthesia. It is an autosomal dominant inheritance conditions, and the trigger agents, it could be volatile anesthetic agent or succinylcholine. It's a very rare but serious anesthetic emergency. The prevalence can range from 1 in 10,000 to 1 in 150,000 worldwide, depends on how's the pickup rate of the MH. The number of cases has fallen over the years, mirroring the reduction in the use of succinylcholine when rocuronium is invented and can be used as a rapid sequence induction agent. The condition was found in 1960, and during that time the mortality is as high as 70 to 80%. But over the years, where improvement on knowledge, early recognition, and denturing administration, the mortality has fallen to almost 4% worldwide. The pathophysiology is due to a mutation of the ryanodine receptor R1 encoded on the chromosome 19, which is responsible for the intracellular calcium metabolism. As we can see here, when that susceptible individual is exposed to the triggering agent, which is the inhaled anesthetic agent or the succinylcholine, it will lower the threshold for the activation of the receptor, causing increased calcium in the myocyte cytoplasm and increase the capacity of reuptake of protein to carry the calcium. This condition will lead to a sustained muscle contraction and hypermetabolism. For the hypermetabolism, it will increase in temperature causing hyperthermia, increase in CO2 production causing increase in end tidal CO2 and tachypnea, increased tissue oxygen demand leading to increased heart rate and tachycardia, increase oxygen consumption and lead to anaerobic metabolism, causing lactic acidosis and metabolic acidosis. Sustained muscle contraction will lead to muscle rigidity and then causing a muscle self-death that cause increase in intracellular potassium release to the bloodstream, and hyperkalemia will lead to dysrhythmia. And muscle death will lead to rhabdomyolysis and increased CK that further lead to myoglobinuria and acute kidney injury. When there's imbalance between a thrombotic and antithrombotic pathway, it will lead to DIVC, and all this eventually will lead to cardiovascular instability and possible coma and death. So the clinical features of MH was rather non-specific. So this is the prevalence of the clinical signs. As we can see, the most prevalent signs was hypercarbia, which accounted for 92%, sinus tachycardia, rapidly increasing temperature and elevated temperature with general muscle rigidity. This is the top 5 most prevalent signs and symptoms, which could be rather non-specific. So for the differential diagnosis, if the patient presented with hypercarbia, tachycardia, rise in temperature, and muscle rigidity, it could be due to anesthesia related, which insufficient anesthesia or analgesia, hypoventilation, and CO2 rebreathing will give rise to a high CO2 in the system, and increased CO2 absorption from the laparoscopic procedure. Or the other possible differential diagnosis, like 2 cases that I shared before, it could be a sepsis, anaphylaxis, anesthesia-induced rhabdomyolysis, thyrotoxicosis or thyroid storm, transfusion reaction, or drug abuse, serotonin syndrome, pheochromocytoma, and neuroleptic maintenance syndrome will be one of the differential. So the management principle comes to reverse the action and to treat the consequences. To reverse the reaction, most importantly, when we suspect the patient having MH, we should eliminate the agent, which is the triggering factor that can effectively eliminate it, which is the volatile agent. So we have to turn off the vaporizer, give 100% oxygen at the maximum flow to wash out the volatile agent, and increase the minute ventilations to wash out the CO2 as well. Activated charcoal can be inserted to further absorb all the remaining anesthetic agent in the GA machine. Dantrolene is the treatment for the muscle rigidity, and active cooling therapy should be instituted. Consequences I will share in my slides later. So talking about dantrolene, 1 vial of dantrolene contains 20 mg dantrolene, and it needs to be diluted in 60 water sterile water. It's a very difficult dilution, and as it takes time to dilute, and the dantrolene vial contains sodium hydroxide to maintain the pH 9 to 10 and 3 grams of mannitol. Like 70 kg patient will need 9 vials of dantrolene. Rhinodex is another dantrolene available in the market, but not in Malaysia. It's much easier to dilute. As 1 vial only need 5 ml to dilute, and it will give you 250 mg of dantrolene. The mode of action of dantrolene is it directly interferes with the muscle contraction by inhibiting calcium ion release from the sacroplasmic reticulum. Adverse effect, it will cause a local irritation due to high pH, nausea, lightheadedness, or some muscle weakness. Timing of administration, according to the North America MH registry, the MH complication will increase 1.6 times for every 30 minutes delay between the first signs and the first dose. Whereas for Canada registry, it shows that every 10-minute delay, complications of MH increase substantially, mostly renal dysfunction. Dantrolene is very effective. It will achieve the therapeutic level within minutes, and you will see the response immediately if really MH is suspected. The redosing depends on individual base, and the goal of the treatment, you might need to redose if needed. So comes to the dantrolene availability. Recently, Malaysia Society of Anaesthesiology has compiled a list of places which dantrolene is available. So in Selangor, PPUM is one of the centers that have dantrolene. Fortunately, almost all the states will have dantrolene, and this is the contact number that all the hospital can refer to in case they need dantrolene. So comes to the management of sequelae. First is the acidosis. Patient will have a respiratory acidosis, then metabolic acidosis will slowly develop. The primary management is hyperventilation, and threshold to give sodium bicarb is lower because evidence shows that low pH value associated with poor outcome in MH. And sodium bicarb will aid in the reuptake of potassium into the cell and alkalinize the urine in case myoglobinuria happens. Second will be hyperkalemia. Treatment again to administer sodium bicarb or give a standard lytic cocktail, but in this case, the lytic cocktail is without the calcium infusion. The IV calcium should only be given in an extremis, as it may sustain the skeletal muscle cell calcium. If the hyperkalemia is not responding to treatment, hemofiltration will be required. The third sequelae will be the myoglobinuria and acute kidney injury. Myoglobinuria should be anticipated, and as the free myoglobin will precipitate in the renal tubules and stimulate the lipid peroxidation, causing further renal damage and acute kidney injury. The treatment is always aimed higher urine output, more than 2 mL per kilo per hour, with given IV fluid maintenance. And dantrolene contains mannitol, it will maintain some diuresis. If the urine output is not achieved, further doses of furosemide can be given. Disseminated intravascular coagulopathy. The occurrence of DIVC is associated with poor outcome. So following the recommendation, we should empirically treat with platelet, fresh frozen plasma, and cryoprecipitate. And the coagulopathy is likely to continue until the hyperthermia is corrected. Tachyarrhythmia. We always use the common and most familiar one. You can give amiodarone 5 mg per kg or use the short-acting beta blocker or magnesium. It's likely due to the electrolyte imbalance, which is the potassium. If the patient go into cardiac arrest, it should be managed as per acute life support guideline. And in this condition, we should avoid use of calcium channel blocker as it may cause severe myocardial depression if used in combination with dantrolene. Compartment syndrome, it should be closely monitored, especially for those who develop myoglobinuria. The CK, as the both case mentioned, it might not peak during the first 24 hours, but it will peak after that. So the monitoring is mainly clinical. In an awake patient, it's easier to monitor as the patient will complain of limb pain. But in sedated patient, a regular assessment of the limb swelling, muscle softness, and peripheral pulses or oxygen saturation is required. In compartment pressure should be measured, and if this happens, the treatment will be fasciotomy. Ongoing care, the patient should transfer to ICU post-op for further monitoring at least 24 hours. Maintenance dose sometimes will be required as the recrudescence is happen in 20% of patients. The goal is to maintain a metabolic stability for 24 hours, core temperature less than 38 degrees, and also without evidence of rhabdomyolysis. So counsel after acute MH is to test for the MH susceptibility for the patient and the family member, which is a blood relative. Until a definitive test is carried out, they are not suggested to have anesthesia with triggering agents and obtain conspicuous identification as they are MH susceptible. Confirmation, unfortunately, is not available in Malaysia or in Southeast Asia, as the genetic DNA testing can be offered, but still it can't exclude the MH susceptibility, and towards the end, we have to subject the patient for muscle biopsy. But the muscle biopsy has to be done in a fresh muscle. So the muscle, Westers muscle is harvested after the local anesthetic block and put in the Krebs solution, and it will remain viable for 5 hours to transport to the lab. And the muscle will subjected to an increasing concentration of halotane and caffeine. However, the fresh muscle biopsy need the individual to go to the center to do it, which is UK or Australia. So management of anesthesia in MH susceptible patient is to prepare equipment which is triggering agent free and use the anesthetic agent which is non-triggering, like all the IV anesthetic agent and all the local anesthetic agent. Volatile agent and succinylcholine must be avoided. Any role in administrative or perioperative prophylactic dantrolene, from the evidence, it says not necessary. So these are my reference, and thank you.
Thank you very much, Dr. Yip, for presentation of the two cases. Very rare, but it occurred in our center. And I think in the end, the outcome of the two cases were good because there's a rapid support system from the whole team. And I must say, I think the pharmacy department also gave us a big hand and help in getting dantrolene. Dr. Yip, I think dantrolene is not cheap, but we have several vials that is enough in the OT, luckily. So now we hand over to Professor Shahnaz to round up of our plans ahead if we ever encounter MH again.
Thanks, Prof. Loh. Assalamualaikum and good morning. As we have heard from Dr. Yip's presentation, both the suspected malignant hyperthermia cases that we encountered recently were managed well by the anesthetic team involved. However, there are some aspects of the management that we thought can be improved further. Hence, Prof. Loh has decided to form a UMMC MH team, basically to look at how we can improve the overall clinical management of future MH cases in UMMC. So this is the initiative by the MH team where they have produced these following items: the MH emergency management guidelines, the treatment checklist, MH patient information sheet, MH card, MH letters, and the case report form for malignant hyperthermia. First, this is the poster on the emergency management of malignant hyperthermia guidelines. This is adapted from the UK Association of Anaesthetists guidelines, which highlight the key principles of management of emergency management of malignant hyperthermia, stressing on the importance of making an early diagnosis, making an early and aggressive treatment involving these three important steps, which are the first to eliminate the triggering drug, to give the antidote dantrolene, followed by active body cooling measures. And we should also closely monitor the clinical parameters of the patient and perform relevant blood investigations. And also to look out for and treat the complications of malignant hyperthermia such as acidosis, hyperkalemia, and tachyarrhythmias. And also manage this patient for at least 24 hours after the initial MH event in ICU or HDU setting. Together with this poster on emergency management of malignant hyperthermia, the team has also produced a poster on MH treatment sequence and checklist. So this checklist is intended to aid the anesthetists leading the team to prioritize and allocate tasks according to the number of team members available. And the tasks in the first box should be implemented first, followed by the task in the next box, which is supposed to be done as soon as possible before we move on to the tasks in the subsequent boxes. The team has also put together this malignant hyperthermia card where you can find the antidote drug dantrolene, the solutions to dilute the dantrolene, also drugs to treat the complications such as acidosis, hyperkalemia, and tachyarrhythmia. We can also find the equipment to cool down the patient's body temperature, the monitoring equipment such as central venous line and the arterial catheter, as well as some laboratory test kits. And all these items are placed in these boxes, which is clearly labeled as malignant hyperthermia card, which stationed in the main operating theatre complex. So we also prepared the patient information sheet, basically to inform the patient on the basic knowledge of malignant hyperthermia, how common is malignant hyperthermia, what are the signs and symptoms, and how is MH treated. And we also prepared this letter for the patient, basically to inform what actually has happened to him or her during their recent anesthetic. This is to prevent future similar MH crisis if the patient is to get another anesthetic in another hospital. And as MH is a genetic condition which is passed on within families from generation to generation, we also prepare this letter for the patient's family members and relatives, because they are also exposed to the risk of developing MH if they are to get an anesthetic in the future. This is the malignant hyperthermia card. This is something like the medic alert card or tag, which the patient can carry with them in their purse or wallet. And finally, this is the malignant hyperthermia case report form. This is an important document to be filled by the attending anesthetist, which contain a detailed description of the initial MH event, the triggering drug, the clinical management, and the clinical cost after the initial MH event in ICU, and also to report if there's any complications related to the MH crisis. So that's all. So we hope that with this initiative by the MH team, we can provide a more systematic, coordinated, and holistic care of managing future patients with MH in our hospital. Thank you, Prof.
Thank you very much for the discussion and introducing our MH team. Previously, the National MH Group has been headed by HKL, but now we will join hands and continue to monitor these rare cases. We've got a few more minutes before we hand over to the next team. Let's have a look at the Q&A and chat box to see if there are any questions for the team here. The chat's about MMA points. We've got a question from Prof. Tunku Sara. Thank you very much for your question and inquiry about this. When you say autosomal dominant, these patients are at risk at every anesthesia that they undergo?
I suppose all the patient will be at risk of anesthesia. It just depends on how it's a spectrum of the presentation. Sometimes patient will just show as a jaw rigidity when we induce the patient. We could never know that a patient could it be really MH susceptible, but if there is a family member having a MH susceptible condition, we should be always very careful when giving anesthesia to all the blood related family member, as their risk of having a full-blown MH is very high.
That's right. I think the moment that we already have someone suspected of it, the risk of developing MH in all anesthetic experience that the patient will go through is considered high. But of course, I think we've discussed the methods that we need to change to be an MH-free anesthetic environment has to be instituted for, early for a safe anesthesia. I think the second question is also related to the incidents, whether MH can happen in normal, non-inherited, in patients who have not inherited the autosomal dominant gene. Perhaps Prof. Shahnaz can just elaborate on that question.
Yeah, so sometimes it's difficult to sort of diagnose. So that's why even for those cases that we encountered, it's just a suspected MH case because we can't confirm the diagnosis because we can't perform the fresh muscle biopsy. So we should have an appropriate index of suspicion during anesthesia, and whenever there are signs to suggest that the patient has features to suggest an malignant hyperthermia crisis. So, and especially when the patient has been exposed to the triggering drugs such as succinylmetonium or volatile anesthetic, so we should treat early and aggressively to have a good patient outcome.
Excellent. All right, I think we've come to an end in our presentation, but I will just sum up to say that MH, although rare, I think three things are important, three points that we note and take back from our webinar today, especially sort of pointers to the non-anesthetic team participants who have joined us this morning. So one is actually awareness of any history in the patient in particular, or any family history that had a very bad reaction. I mean, our normal population would just say that it's a bad reaction to anesthetic, a drug or something has happened, and patient had had to go to ICU for a seemingly very simple case. So that should trigger some awareness, and then we've got to really ask into the history. Now, the second point is a rapid diagnosis of these cases. They can be very subtle or plainly there with a very high temperature, sudden acidosis, certain problems that could not be explained. In a way, it's an exclusion of diagnosis, but a high index of suspicion of the clinical features must be instituted for its diagnosis. Now, lastly, I think teamwork is very important. Once we suspect it, the whole team, a lot of people must come in to actually activate a rapid response team in the OT, because these cases, if left untreated or sort of a delayed treatment, will then have very high severe mortality. So with that, we end the session from the anesthetic department, and I shall hand over to the next presenter from the ENT department. Thank you very much. Have a good morning.
Thank you very much, Prof. Loh. Assalamualaikum and very good morning. Welcome to the first episode of Breakfast at UMHealth for 2022. I'm Dr. Shams from Department of Orthopaedic Surgery and will be moderating the next session. So Dr. Revadi is our next speaker. She is ORL Head and Neck Surgeon at the University of Malaya since 2018. She completed her training in 2010 and subsequently underwent a 3-year subspecialty training in rhinology in the Ministry of Health, and with a 1-year tenureship in Adelaide, where she trained with the world-renowned sinus surgeon, Professor P.J. Wormald, involving advanced endoscopic sinus surgery, anterior skull base surgery, and endoscopic lacrimal surgery. So she is currently part of the rhinology and skull base team and runs the olfaction clinic and is actively involved in the research for taste and olfactory disorder. So she will talk to us today about olfactory diseases in view of the COVID pandemic. So without delay, I would like to invite Dr. Revadi to share her presentation. Welcome, Dr. Revadi.
Thank you very much for your kind introduction, Shams, and a very good morning to everybody. Okay, so I will start this talk to begin with. Let us just look at the intricate system that actually makes up the olfactory pathway. And here, a diagram from that was published in the journal Science. We can see how this intricate system has such an amazing capacity to discriminate up to at least 1 trillion olfactory stimuli, far more than what we can perceive in terms of colors and tones. And so how do we sense this trillions of olfactory stimuli? And when we say olfactory stimuli, they're basically odorants which are made up of diverse components of molecules. And once this enters the nose, it dissolves in the mucus layer within the olfactory cleft. And this odorant molecule then attaches to the olfactory receptors, which activates and allows the olfactory neuron to send electrical signals to the brain, first relaying in the glomerulus, which is situated in the olfactory cleft. Then the signal passes on to the mitral cell before finally reaching the olfactory cortex for interpretation. So when we look through the nasal endoscopy, we can actually see that the olfactory epithelium is actually a tiny space of about 2 centimeters square, occupied, which is located between the superior part of the middle turbinate and superior turbinate and the superior part of the septum. And if any further dissection is done, you can actually see these filaments, the olfactory axons, bundling together as filaments of olfactory filaments, passing through the foraminas in the cribriform plate. And if you use the electron microscopy, you can also see how this olfactory sensory neurons also has multiple dendritic cilia, which actually extends the cilia into the overlying olfactory neurons, mucus layer. And this olfactory epithelium actually contains millions of such neurons, okay, estimated to be between 6 to 30. And it's also unique in the sense it regenerates throughout life. The lifespan is actually short, between 30 to 90 days. And another aspect which also accords a unique feature to this olfactory sensory neuron is that each olfactory sensory neuron encodes only a single receptor protein. And all sensory neurons that encode such protein is collected by a single dedicated glomeruli in the olfactory bulb. But this signal, when it goes to the olfactory cortex, then it sort of overlaps. So for us to be able to perceive a scent, we actually get a combination of signals from the olfactory epithelium, which goes through this process. So this remarkable discovery is what earned two scientists, Linda Buck and Richard Axel, Nobel Prize in 2004. So such an intricate system is in place for a reason, and it is really important for the overall well-being of human. And in terms of nutrition, it allows us to detect edible food, reject spoiled food, and also to regulate our appetite. It protects us from environmental hazards. It allows us to detect smoke from fire, a gas leak, or a decayed food, and also it is important for social behavior, in improving the mother-child bonding and also in romantic relationships. But despite all this importance, smell disorder is underdiagnosed condition, although the prevalence is between 3 to 22% in the general population. If we break it down, quantitative hyposmia or a smell reduction accounts for for most of the smell disturbance, and followed by a more severe reduction to the extent that there is no proper function. and that accounts for about 3.5 to 5.8% within the general population. There are some people who cannot smell one certain odor, and this is actually known as specific anosmia. This is actually normal and a non-pathological phenomenon. There is also another aspect of a smell disturbance, which is known as qualitative hyposmia. And what constitutes qualitative hyposmia is parosmia and phantosmia, which are both less common conditions. Parosmia is basically a distorted perception of a real odor, which basically means if, let's say, you have a smell of a rose, but the person actually smells it as a garbage. Whereas phantosmia is the smelling something when actually there is absence of such odor in the vicinity. So some of the causes of olfactory disorder, the commonest is the sinonasal disease, and examples of this would be chronic rhinosinusitis, nasal polyps, and this is followed by upper respiratory tract infection. And most of the common causes would be those viruses that cause common cold, which includes the rhinovirus, influenza, and parainfluenza, and so on. And of course, during this pandemic, COVID-19 induced anosmia is prevalent. The mechanism is not really known, but some of the proposed mechanism includes the olfactory cleft edema, injury to the olfactory epithelium due to direct invasion of the ACE2, and also the transmembrane protein serine protease receptors. And some of the other injuries are also due to direct infection and apoptosis of the neurons. And in some studies, the injury to the olfactory bulb has also been identified. In terms of prevalence, how common is it? Really, the prevalence is really variable. It really depends on whether the data is collected from self-reported patients or those tested objectively, or whether the data is from a hospital setting, home isolated patient. It also depends on the geography from where the data is coming from, and also at which time point in the pandemic the data is from. But overall, we have 3 meta-analyses from the year 2020, and irrespective of the differences, the prevalence is roughly about 43 to 47%, and Caucasians have been found to have 3 times higher prevalence as compared to Asians. And of course, if you look at it in a more objective studies that included more objectively evaluated patients, the prevalence is higher as compared to patients who reported olfactory disorder if they have self-reported data. And if we break down the types of smell disturbance, anosmia and hyposmia constitutes a prevalence between 35 to 36%, and dysosmia or parosmia are less common. Parosmia has been noticed in COVID-19 induced patients to occur during the recovery period, as delayed as 2 to 3 months after the onset of the illness. It could even present as the only symptoms. And usually it tends to be unpleasant. And some of the common triggers that has been reported are coffee, onion, garlic, meat, and also citrus, along with toiletries such as toothpaste. Spontaneous recovery is reported between 31 to 89% to occur within 9 to 10 days. But if you were to take the same group of patients and test them objectively, the actual number who have a complete recovery is much lower, and which really means that patients' perception of recovery is actually is actually more than what they actually the actual olfactory disorder that is present. And beyond 6 months, the literature reports persistence of olfactory disorder in this group of patients between 7 to 11%. And some of the risk factors that have been identified includes older age, diabetes mellitus, and also longer duration of COVID-19 illness. Apart from these 2 causes, traumatic brain injury is the next common cause, followed by idiopathic causes. And interestingly, olfactory disorder is also associated with neurodegenerative disorders such as Alzheimer's and Parkinson's. Here's the immunofluorescence section of the human olfactory bulb, where we can see the aggregates of the proteinopathies, and it is reported that these proteinopathies have an initial and preferentially affects the anterior olfactory nucleus, which then leads on to a preclinical. So hyposmia and anosmia could be a preclinical sign of Alzheimer's and Parkinson, and it can actually predate Parkinson's disease by even by 10 years. Of course, there is a long list of toxins that can also cause olfactory disorder. These are some of the list. And we have seen so many etiology, and so how do we come up to diagnose them? Of course, history is really important, very detailed history. And this should be followed by a standardized psychophysical test. We know that self-reporting is inaccurate, as 1 out of 3 individuals tend to underestimate their olfactory abilities. And there are a number of psychophysical tests which is available globally, and the most common is the otonasal smell test. And otonasal smell test, and this is probably one of the common one which you may have encountered, the University of Pennsylvania smell identification test, but this is not really used in Malaysia. We do not have a culturally adapted version. But what we use is the sniffing sticks test, which has a culturally adapted version in Malaysia. And we have another culturally adapted version of a scratch and sniff test. This is TIPSIT, which is from Taiwan. Those are more comprehensive tests, but we also have screening smell tests such as the po-item pocket smell test, the QSID, and also the smell discards, which can be actually purchased online. Okay, so apart from this tool, there are other modalities for diagnosis. This is olfactometer, which records the event-related potentials, and also imaging such as functional MRI. But none has reached routine clinical applications. I will not go into too much of detail. But what is really important is ENT assessment. Okay, so during ENT assessment, what we do is actually a nasal endoscopy after decongesting the nose. And what we actually do during this nasal endoscopy is that to carefully evaluate the olfactory cleft to look for discharge, polyps, edema, crustings, and scarring. I'll just share with you some of the endoscopy pictures that from our collection, from our olfaction clinic. And this is an endoscopic image of the nose, the left and the right nose of a patient who had developed a gradual anosmia over a period of 12 years. And the 12th year, she became really frustrated, as the children started scolding her because she was unable to detect the cat poo, and the house started smelling. And when we did the endoscopy, this is what we found: tumors within the olfactory cleft, and the biopsy revealed respiratory hematomas. And this is another patient, has got a tumor between the septum and the middle turbinate. Another patient who had a gradual anosmia over 2 years. She dispelled it as something trivial until she developed epistaxis, and the biopsy of this patient later turned out to be an olfactory neuroblastoma. So those are more rare causes of olfactory dysfunction. And what's more common is inflammatory conditions. So here in this picture where the arrow is, you can see edema between the middle turbinate and septum where the olfactory cleft is situated. And in this image, you can see how edema of the middle turbinate itself is actually obstructing in the olfactory cleft. And in this image, you can actually see where the arrow is the presence of polyp between the olfactory cleft. So how about post-infectious olfactory disorder and post-traumatic? In general, the nasal endoscopy is usually normal. And so we need to rely on the history and also the imaging to diagnose, especially for traumatic causes. So how do we treat them? So in terms of tumors, I think surgical therapy intervention is what would most likely be needed, depending on the histopathology. But for those who have post-infectious olfactory disorder, about 1/3 of them do undergo spontaneous recovery, so which leaves the remaining, to be treated. The prognosis for those with a traumatic brain injury is actually very variable depending on the extent of the tumor. So what are the treatment options available? There's been many interventions that has been tried for, especially for post-infectious olfactory disorders. And what we will discuss today is just olfactory training and steroid, which are the most recommended treatment options. So olfactory training is basically a rehabilitation treatment. And what the patients do is that they sneak the essential oils of let's say rose and lemon and eucalyptus oil and clove, and each essential oil is sniffed for about 10 to 30 seconds and sequentially, and for about 2 days up to about 12 weeks after 12 weeks. This is a classical olfactory training. And what the olfactory training does is that nobody really knows the actual mechanism, but what has been hypothesized is that it actually helps to regenerate in the regeneration of the nerve and also improves the higher order processing. There are also, along the way, there have been a lot of modifications to this olfactory training to improve the outcome. Nowadays, there is also researchers who have found that increased duration of olfactory training, the use of higher concentration odorants, and also the changing of the sets of odorants have actually improved the olfactory training. More recently, there have also been research that showed that there are other chemicals which have anti-inflammatory as well as antiviral properties, and this includes to very common ingredients such as turmeric, thyme, peppermint, lemongrass, and lavender. So these are actually essential oils that can be used as an alternative by patients who are performing olfactory training instead of the classical four, which is the rose, lemon, eucalyptus, and clove. So we'll go on to steroids. Both oral and topical steroids have shown benefits in terms of olfactory improvement in patients with chronic rhinosinusitis with nasal polyposis. But the evidence is somewhat weak for non-chronic rhinosinusitis patient. Steroid rinse has shown improved outcome in selected patients, but topical steroids have not shown much improvement, so it's not really recommended. But for post-viral olfactory disorder, the use of short-term systemic or topical steroid is a good option in selected patient, and this has also been recommended by the Clinical Olfactory Working Group consensus statement on treatment for this post-infectious olfactory dysfunction. Specifically looking at COVID-19 and the use of steroids, there have been a lot of publications with very mixed results, and I think there's a lot of studies which are still ongoing, but the results are leaning towards benefit. So all these patients need to be carefully assessed so that we can give them an individualized treatment. And this is a new head position that has been described about 6 years ago, where, it's especially if the physician is using a topical drop. This is known as a Kaiteki head position. This allows the topical drops to reach directly the olfactory cleft. Okay, so this is something that we are also doing in our olfaction clinic. And apart from steroids and olfactory training, other supportive measures are also equally important. We need to counsel the patient about their dietary intake, to monitor their food expiration date, and also to make sure that they have to make sure that the natural gas detectors or smoke detectors are functioning. That they smoke, we encourage them to stop smoking. And I think it's also very important to refer them for mental health services, especially if this olfactory disorder has actually led them to develop depression, anxiety, and other mental health issues. So this is a patient support group which we routinely recommend to our patients. They're very active, especially during this pandemic, where you can learn about many things, alternative things that other patients have tried and worked for them. And they also have a very good guide on olfactory training and so on. And with that, I think I've come to the end of my presentation. I'd just like to reiterate again that olfactory disorder has got multiple etiology, and I think it's very important that any smell disturbance is not spelled as trivial symptoms, and they should be referred for an assessment so they can be given the appropriate treatment. Thank you. You can actually directly contact me if you are a patient with olfactory disorder yourself, or you have a patient, or you can email me at this email. Thank you.
Thank you very much, Dr. Revadi. I think we've got quite a few questions lined up. Okay, let's just go straight. Number one, has phantosmia been reported with ghost sighting? And there's a person who believes in such presence more likely to report phantosmia.
I am not sure. I've not had a patient who has reported ghost sighting.
Okay, next one, how to differentiate hyposmia or dysosmia from just reduction due to nasal blockage due to rhinorrhea?
The question is a little vague. How to differentiate hyposmia? So
Yeah,
a nasal blockage can be a cause of hyposmia. So the only way we can actually differentiate that is that conclusively is by doing a nasal endoscopy. So if we can see inflammatory process going on in the olfactory cleft and the patient has nasal symptoms, so we know that this is a conductive type of sensory loss leading to hyposmia or even anosmia.
So in COVID patients, do they get this inflammation?
Yes, some of them, not all of them, but most of the patients that I have seen post-COVID, they generally tend to have a normal looking nasal endoscopy. Okay. But also again, they come after the infection is over, at much later referred, after they go through their MDT for COVID. So I'm not sure whether this is were present earlier and which has resolved.
Okay, if we use home items for the self-test, is there a way to grade the severity or even anticipate improvement?
Yeah, so depending on what you use, so there is usually there is a scoring. So you can actually look at your scoring and you can monitor your scoring. If there is improvement in your scoring, which really means you are improving.
Okay. Next, conversely, can one treat or slow down dementia, example by exposing to different smells or olfactory training?
I don't think we have an answer for that, but I suppose olfactory training is actually a very simple thing to do. And I think if you have family history and all, perhaps it's something that you can try on.
Okay,
how do you treat the olfactory
tumors?
Tumors. Okay, so olfactory neuroblastomas are actually is a skull-based tumor. So depending on the extent of the tumor, we actually it can be done purely endoscopically, but if it encroaches intracranially, then it's usually a combined surgery with the neurosurgical team. What we do is that a surgery called anterior skull-based resection.
Relating to the tumors, I'm just curious, the tumors that cause dysfunction, are they mainly benign or malignant?
So like respiratory epithelial hamartoma are benign. You saw one of the first picture, but olfactory neuroblastoma is a malignant condition.
But which one is more common?
I think respiratory hamartomas are more common, but although not picked up as much as we should be picking up, yeah. Because it can look very much like a polyp.
Okay. Just I think if there are no more questions, one last question from myself. I'm just wondering whether if we do regular douching, does it help with people with a chronic CRS?
It actually
Regularly.
just I think it is a more of a symptomatic relief rather than in a more of an adjunct treatment rather than actually treating specifically the underlying etiology. So I think a steroid, a topical steroid is what will actually help you with the directly with the inflammatory process. Douching is just an adjunct treatment.
Okay. All right. I think that's it. We're 1 minute past 9. So there are no more questions. Okay. Thank you very much, Dr. Revadi, for sharing.
Thank you very much, Shams, and thank you to everyone.
Thank you everyone for attending. So that we come to the conclusion of this week's session. Do join us for next week's breakfast at UMHealth. Thank you and have a very good Wednesday. Bye.
Thank you. Bye.